Stay right there. I don't. Oh. All right, guys. So, right. What you will see, because I went through it last night, just quickly. It's the same thing that we've been looking on all the time. It's the same thing. When I look on the papers, it's the same question they ask all the time. Same question. Okay. Anyway, so let's go through it now. So the top picture. Usually we show the hypoglossal foramen or canal from the inside, but sometimes people have it difficult to actually recognize it from the undersurface like that. Okay? But you can see that it's just above the condyles, the condylar processes, right? So if they put a pin there, of course we know that it's a hypoglossal canal. And then, so name the opening traversed by pinnae, hypoglossal. Functional significance of the structure passing through it. And from a city question, I know exactly whose question is this. Because that's exactly how he asks it every year, same old thing. And sometimes he says the structure passing through here are motor too, right? And as you can see, the muscles of the tongue, right? Anything else pass through that for me, you think? All these things you already know, you know. But anything else pass through there? Liz, what else pass through there? Oh, there's not pass through there. Alright, the next picture now, the lower of the two. Which muscle is attached to where that black thing is? Black arrow, I think. And it's right, it's the lateral pterygoid, as you can see. Lateral fovea. Yeah, so that's the, yeah, you can call it the neck of the mandible or the pterygoid fossa or fovea. And that's the lateral pterygoid. Remember, the lateral pterygoid is a triple insertion, right? So the other two places would be the capsule of the TM joint and the articular disc. Good. Remember also that to depress the mandible, you have to protract it, pull it out, and then it drop down. And then somebody who laughs and dislocate the TM joint, you can just push it back in, right? I've seen somebody come into the A&E with the mouth open and they can't close it. They went to see a movie and it was hilarious. And then when they're ready to close the mouth, it wouldn't close. So it got dislocated, right? Alright. Yeah, the only thing I don't like B. I don't like question B2 though. Because if my memory serves me right, that's not a good question, to be honest with you. Because function and action, if my memory serves me right, is not the same thing. And I think is the action he asking for, and he shouldn't say function. And I mean, I'm not, I'm no big thing, to be honest with you, but that's how I knew it. The former head of this department would take a knife and cut my throat if he ever see me ask a question like that. So that's the real question. Although these days anatomy is getting watered down and nobody cares anymore. But I don't think that's the right way to ask the question. It's the action. I think function though is like chewing or something like that. But action is flexion, extension, protraction, retraction, and those things. Alright, anyway, move on. So, hold on. Maybe that's the last question. So where's the first question? Why are we on 11? That's terrible. No, that shouldn't be my first slide. No, that is not my first slide. It's terrible. Come on. What are you talking about? Let me try something. That's not
12 is your next slide, look.
No man, it's supposed to be 1 and there's 2. Alright, let's leave it like that. Maybe that's how it is. Okay, good. Let's look on this one now. So the structure the pin is on, I've shown you that already. It's hard to see, but it's a little projection right beside the mandibular foramen. See it? Oh. Everybody see that? That's the mandible there, and that's the mandibular foramen. You see it? Mm-hmm. And remember that little bony projection, I always tell you to use your finger and touch it. Mm-hmm. It's the same projection I tell you the dentist when he puts his glove on, puts his hand and feeling, he's feeling for that. And once he feels that, he can now let the anesthetics go in the general area. I can't put the needle in the mandibular foramen because he cannot see it. Mucosa is over it. So the best he can do is put his hand in there to find something that can guide him to where the mandibular foramen is. So once he feels the lingula, then he knows the mandibular foramen is nearby. Then he'll go the anesthetics, right? And hopefully it will seep into the mandibular foramen and get into the inferior alveolar nerve. Okay? And then once that happens, what will happen? The lower lip gets numb, all the teeth on the mandibular side, mandibular thing get numb, everything get numb, right? And then he can extract the tooth or do whatever he wants, then you feel minimal pain. Alright? So if he asks you, what do doctors actually use the lingula as a guide for, then you can say to locate the mandibular foramen and to introduce an anesthetic or whatever. But I always ask you what is attached to that structure. And you can see what the answer is, right? So what about the stylomandibular ligament? Where that one attaches? It attaches to the angle of the mandible. But the spheno one attaches to the lingula. And then just to, for sake of completeness, sometimes he asks, what is that an embryological remnant of? I would say it's Meckel's cartilage, which is different from Meckel's cave, right? Meckel's cave is where? What's Meckel's cave? What's the difference between Meckel's cartilage and Meckel's cave? Come sit down now. Meckel's cartilage and cave, guys. Meckel's cartilage is the location of the trigeminal ganglion. Not true?
Meckel's cave.
Meckel's cave, yes. What did I say? Cartilage. Let me put in a new chewing gum. Maybe I need some like glucose, hypoglycemic or something. Alright, good. So let's move on now. So moving on to B. Which nerve emerges from this foramen? And not B2, B1. Which nerve? That's the greater palatine. That's the greater palatine foramen that B1 is in. See that? Good. Greater palatine foramen. So if you thought that was just respiratory, it's digestive too. You agree? What does that nerve supply? It supplies the mucosa of the hard palate. And what modalities does it transmit to the mucosa of the hard palate? Is it taste? Is it taste? No, nothing to do with taste. So it's general sensation, and what else? Parasympathetic and sympathetic. You have to remember these things. So write it down. Right? Remember, greater palatine is a branch of pterygopalatine ganglion. And all the branches of pterygopalatine ganglion have 3 things in there except the one to the soft palate, which have 4. Right? The one to lesser palatine has taste in addition to those 3. So general sensation coming from maxillary, right? Sympathetic coming from the deep petrosal, and parasympathetic coming from the pterygopalatine ganglion. Right? What Jesus can't have you know, he's busy trying to save other people.
That's not true, sir.
Yeah,
What? Of course you can.
Of course you can.
what am I going to do? Tell me what he's going to do.
You can save us.
No, he doesn't do that. And why would he help you and not help somebody else over
Why
there?
not help all
Help
of us?
everybody.
No, do that. Have a time for that, man. Don't waste your time. Come, let's go. Ready? Think Jesus is in the business of helping anatomy students all over the world? That's not his job. Anyway, come.
They're killing somebody's spirit.
Anyway, I'm just joking. Come. Greater palatine. Alright. Yes. So yes, carotid plexus. Right. Carotid sympathetic plexus. Okay? Which is actually post-ganglionic sympathetic fibers from the superior cervical ganglion. Right? Okay, so where are we now? Yeah. So that's the greater palatine foramen. Anything else travel through that foramen, guys? Greater palatine artery and vein. Okay? Good. Greater palatine. As a matter of fact, the greater palatine artery creeps up from there, everybody. Creep up from there and goes into B2. You get that? Alright. So B2, which nerve emerges from this foramen? Liz? Is it Biz or Liz?
But the answer is in our face.
So it's nasopalatine, right? Nasal. No, I'm good. There's nasal. Everybody? Okay, nasal palatine. So what modality is the nasal palatine transmitting to the inside septum? CM3, like greater palatine. Everybody agree? Yeah, because it's a branch of the one. Cerebral palatine. Alright. So moving on now. So hold on, did we do 13? So I don't understand what's going on. Oh, it's 13 there now. Alright. So 13, identify the structure pierced by pin A. We all see that. I always ask you that. Right? Remember? I always ask you that. And in fact, that one, along with the two on either side, are the foundation, what form the foundation of all three of them? Huh? What? Yeah, man, but we're gonna do everything. We don't just want to ask what it asks. We want to cover everything, right? So all three. So that's the median glossopepiglotic fold, and you have a lateral on either side. Now, what I'm asking you, what forms the foundation of all three of them? The higher epiglottic ligament. Good. Just to make sure, because we don't know if everything will come back just like this. Don't you? Alright. So observe the rounded structure pin B1 is in. You really can't see, but we know what it, from the answer what it is, right? So which nerve provides general sensation to it? And which is the nerve? Glossopharyngeal nerve. So which nerve transmits taste from it? Same nerve. Same nerve. Everybody agree? Yeah. So that thing the pin is in is there for what? A circumvallate papillae.
Oh.
A circumvallate. Remember the question saying observe the rounded structure.
Yeah, B2 and
No man, B1. It's a rounded structure, right? That means it's a circumvallate papillae. You agree? Good. Circumvallate papillae. Yeah, it's kind of round for sure. So which type of epithelium now occurs at pin B2? I can't even say what pin B2 is, but it's a general idea. What do you think? B2. Well, you can peep over to the hand. So what do you think that area would be though? Huh?
Maybe stratified squamous non-carotid.
For triangular membrane, is that? What do you think? Anybody? Anybody? What do you think that area B2 could be? It looks like it's behind the larynx, right? Not true? Yeah. See the epiglottis in front there? So that area could be what? Laryngopharynx. Yeah. So that entire area is laryngopharynx, guys. Not true? So which part of the pharynx, which is the only part of the pharynx that does not have stratified squamous epithelium? The nasopharynx. So both the oral and laryngeal stratified squamous non-keratinized. Right, so let me...
Can you tell me the various parts of the oral cavity?
The what?
Can you tell me which part have stratified, which part don't have stratified?
Yeah, man.
Keratinized.
No. No part of the pharynx has keratinized. No part of the human pharynx. Oral cavity, the only part of the oral cavity, guys, that have keratinized epithelium. In fact, lip is not oral cavity. It's not oral cavity at all. Okay? And so what I have seen, because we have slides where the hard palate is lined by stratified squamous keratinized, but that's not on human pharynx. We get it from dog and cat and rat and all those things. But humans, there's no keratin there. The cheeks? No, there's none on the cheeks. The outside of the cheek, yes. But that's not oral cavity.
So filiform.
Oh yeah, filiform, but that's tongue. But that's tongue, right?
That's in the oral cavity.
Yeah, but that's tongue. So that's tongue, it's a structure, and it's in the oral cavity, yes. But it's tongue. And then the only part of the tongue that has the keratin is the filiform, yes. Okay? Alright, so problem, guys. Can't get this picture.
Just press next.
Alright, no I haven't. Okay, so in the region marked by pin A, where does lymph flow to? I will see the answer. We get that right? Alright, very good. Where does lymph ultimately drain to now from there? I will say the answer again. Jugular homohyoid nodes. Yes, so from submental node to the jugular homohyoid
So
node.
submandibular first. So sir.
Yeah.
Submandibular goes there as well.
Yes. Alright, come. What about the region marked by pin B now? Note that is lateral to the laryngeal inlet. So what is that? That's the piriform recess. I don't like the word fossa, I call it recess, but I guess you can call it fossa. Because I've heard people call it that. So what are the boundaries now of that fossa? So the medial boundary is what? The quadrangular membrane. Now what about the lateral boundary? No sir. No man, look, you see that quadrangular membrane you're talking about? The upper border is the arterioepiglotic cord. So what's on the outside?
What is the outside?
Right, so I can't hear you. What is that?
No, I was never mind.
Okay. Yeah man, so it's a Jordan. Just Jordan. Just point, just put your finger somewhere for me. No, over there, like that. Good, right there. A little more medial. Good. That's the medial wall, guys. See? And that's the quadrangular membrane. And the upper free border is the arterioepiglotic fold. See that? So what is the lateral border over there now? Huh? Alright, thanks. That's lateral border. Yeah, the thyroid cartilage, right? Alright, come. Let's move on now. So, why do you medical students need to know about this recess? Yeah, foreign bodies can end there. And I often tell you that they find out that here and there.
They often find what?
I'm sure mine has a lot of here and there. But, okay, you don't need to know that. Sorry about that. Very good. Alright. Yeah, so they find rice grain in there, peas grain, all kinds of things.
He's great.
Yeah. And they can find calculi there too, okay? Stones. Alright, come, let's go. What is the nerve supply, guys? And by the way, carcinoma often occurs there too.
Expected.
Yeah, so what's the nerve supply? We always say it's internal branch of the superior laryngeal, right? Alright, good. Now, going back to that arterioepiglotic fold, what is the line? What's the line? The epithelial line?
Epithelium.
Epithelium. The lining? It's respiratory. It's respiratory. Alright, so let's move on now.
Pseudostratified, goblet cell.
Somebody asked that? Who asked that?
Nobody.
Okay. Alright, come now guys. Moving on. Quick. We have whole heap in guys. Whole heap, come. The region marked by pin A has sensory innervation. This is another thing I keep telling you about. So it's the labial branch of infraorbital for A. And for B, you can say labial branch of the mental nerve. You know? What I don't like about this new system is that in the past, you could say inferior alveolar nerve too. But it'll be. Not sure. But since the multiple choice is only one answer going me there, and I think for you guys it's unfair. But I guess they can always argue that the answer is there. Yeah. So what about the motor supply to the muscle that lies deep to either of those pins? The facial nerve. Facial nerve. Very good. Alright.
Wait, can you go back?
Yeah? So remember the muscle with the orbicularis oculi, right? I mean Oris, sorry. You get that, Dan? Hmm? No, what I'm saying is, so for B it's mental nerve, and for A it's infraorbital. But I'm asking the motor supply to the muscle deep to either of those pins. It's the same muscle, orbicularis, or it can go all the way around. So that's facial, right? Alright, so moving on now. Alright, so this one now. Identify the structure indicated by pin A. If you look closely, Jordan, can I borrow your fingers again? So look here. Go all the way, go up more. No, not come down. Yeah, go over to the that lumen slightly to the left. Good. See there? Go up a little more now. Good. What is that? That's the trachea. Good. And so the esophagus, you can use the trachea now to work out what that luminal thing thingy is in, right? That's the esophagus. Thank you, sir. And it means that those two viscera, those two solid viscous on either side will be the lungs. Of course, you're not doing lungs, but you should know about the topographical relations of the esophagus.
Yeah, man.
Right? Yeah. I mean, that's it. You should know. Of course. So that's the esophagus, guys. Come, let's move on now. At which vertebral level does this structure pass through the diaphragm? And the answer is there for you to see. So these are the things they're going to be asked. Right, this is a nice question. Usually said this is a nice question. So the pericardium covers which chamber of the heart is related to structure A. In other words, what they're asking you, that structure A is an important posterior relation of which chamber? And that's the left atrium. Okay? Left atrium. And that's the whole genesis of heartburn when you get esophageal reflux, right? Alright, so moving on now. Venous blood from A will drain to its system of veins, and you can see azygos and hemiazygos. You mean where? Yeah, it's anything, you know. Come, moving on. Now guys, I have asked you this before. A, look what pin A. It's hard for you to see, so I'll just tell you clearly what pin A is in. The bottom picture is the stomach, open up. And you have seen it before because I've shown you. And the pin is in the musculature of the pylorus. It has gotten quite thick there where the pin is. And we know that's the nerve of Latarjet. So it's in the pyloric sphincter, A2, nerve of Latarjet. They spell it slightly different from me. Maybe my spelling is wrong. But I know it has Latarjet. Yeah, T-A-R-G-E-T. F-J-E-T. Last spell like what me spell it, so that means that they're wrong. I spelled them wrong. Alright, come. So guys, what is the importance? So B1, structure the pin is in. And again, I've shown you this too. Those are the gastric streets, right? And then we said the importance now is where fluids flows. Alright, so we're going over on the other side now. Good. So the entire length of structure A1. What is the entire length of it? 25 centimeters, right? So remember that the duodenum is one of a couple of things in the body that are 25 centimeters long. 10 inches. So I tell you, I remember a consultant sits on a ward room with a guy and he keep asking every question the consultant asks, the guy answers the questions right. And of course they get annoyed when you get everything right. So he look on him and says, why was the metric system introduced? And the guy was there trying to fix it. And he says, so that people like you with 3 inches can have now, with 3 centimeters, 3 inches can have 8 centimeters. Alright, so A2 now guys, A2.
You have to leave the word needed.
So A2 guys, at this point, the artery supplying this structure is a branch of So, so guys, you can see a couple of things on that slide. You can see the head of the pancreas. So you know exactly which part of the duodenum it is. Up further, you can see the pylorus of the stomach, right? So we know it's the first part of the duodenum. So it's the branch of the gastroduodenum. All right. Then B1. State the posterior relation. Posterior relation. So you see B, and you want posterior relation. Now you're going to say what? Right kidney on the highland of the kidney. So, what's the take-home message, guys? You don't just need to just know the thing, you need to know the relations too. You can ask you that. Guys? The it's actually an inconstant artery, as you know, guys. Everybody know that? The supraduodenal. And what do you think that's a branch of? Well, it's most often a branch of the gastroduodenal, yeah. But it's not everybody have it, you know. We have seen several specimens with none. Of the common hepatic, yes. Common hepatic. Yeah. Okay, or sometimes even the proper hepatic. So when does the common become the proper? After the gastroduodenum comes out. So everybody, what is it now? Yes?
Where would that apply versus the gastroduodenum?
Yeah, so everybody, so the pancreatic duodenals, of course, you know, there are two of them, right? Superior and inferior. And they basically supply the head of the pancreas and the second part of the duodenum.
Which one?
The pancreatic duodenal. Head of pancreas, second part of the duodenum. Alright, so lymphatic drainage now. So see the answer there again, paraduodenal nodes, right? Good. My advice to you guys is go through these things, open your Netta Atlas and just look. But don't make these things come back and you can't answer them. You know, there are some people that I study well. Mr. Garner is one of them. You see, it's a specimen like this. He will set this and take it up after the exam with the pins in there on a cardboard and store it away in his room in some cupboard. Exam come, just take it out. The pin is in there already, nothing to change, no pin. And the question paper is there, everything is there. You understand? So this is a guy who's, huh? No, I know him, you know, I've studied him. I've walked over to the university maintenance department and see them have a sale. They're selling slippers, flip-flops, and you buy 10 pair.
You buy 10 pairs from sale?
Yeah, for
You
sale.
may be observing him a bit.
Or they're selling some overall, some peak shirt that these what do you call them? That the laborers wear, and you just buy 10 shirts. And just wear one for like 3 years. Tear up each year and then go. Alright, come.
Savage.
And I'm not disparaging him, you know. Somebody I like a lot. He's my friend. Alright, come. 19 now. A1 identified. Now if you look on A1, guys, what you can see is on the left, you see the cecum and the ascending colon. And then A is heading straight to the cecum. So we know exactly what that is. That's the ileocolite. Alright? No, I'm saying if you look on the thing, what they do, they set the thing up in such a way. Look on the left side. You saw the bow, it looks a little bigger than everything else. That's the cecum on this side, on the left side. Yeah, right. I see the ileum on the right side.
And you said it goes straight to the You said the artery goes straight to it.
You said an artery is going straight to the cecum. So now guys, we already discussed that the celiac trunk comes off the abdominal aorta in relation to T12. And then below that at the level of L1, that's where the superior mesentery comes off. Then at L2, we know two sets of vessels come off the abdominal aorta. The renal artery and the gonadal arteries, you know, ovarian and testicular. And then at the level of L3 now I have inferior mesenteric. And then between L3 and L4, or L4 and L5 I should say, the abdominal aorta bifurcate. So that's the end of it.
Between L4 and
L5, yes.
So south of the arch comes out.
Yeah man, you have the lumbar vessels come off back or posteriorly. Okay, moving on now. Moving on. Now, the artery, which this is a branch of, arises. We'll go through that already. B1, identify the structure. B1. Okay, so if you see B1 there, that vessel is near to the bowel. Near to the bowel. And that I think that's a lot increased question. Vasa recta. So the terminal branches form a plexus in which layer of the gut. You don't have to look on that a second time because there's only one layer of the gut of any plexus, and that's the submucosa. And how much plexus is there? 5 or 6? 4. 4. Okay? 4. So we know that you have a plexus of arteries, you have a venous plexus, lymphatic plexus, and then you have the mycinous plexus. Sometimes they like to put the point across the mucosa now in the GI, in the histology, or even in the gross. I see them do it sometimes. I ask you, blood supply to this area is derived directly, and they underline the word directly from where. So blood supply is from the submucosal plexus. So moving on. All right. Next one. Observe the structure at pin A. Well, I can't see so well, but I can assume what it is. I think I know what it is. How many are to be found in a given section of the gut? So clearly you know what that is. That's the tinea. Yeah, that's the tinea. You're saying something, Daniel? What? Yes. So the 4 plexuses, an arterial plexus, you have a venous plexus, and then we have a lymphatic, and that nervous plexus, right? So remember now that venous blood from the mucosa of the whole GI is going to drain into a plexus of veins in the submucosa. And then the veins that leave the particular part of the GI will collect up from this plexus and leave, right? Same thing again. The arteries, all these various arteries, left gastric, right gastric, hepatopancreatic, blah blah blah, all of those. Once they pierce the musculature, they're going to break up into a plexus in the submucosa. And then little arterioles now leave the plexus and go supply the mucosa, right? So that's the thing. And there are surgical and medical implication of all of these plexuses. Okay, so we'll talk about that. Moving on, again, A2, motor supply. Motor supply, and that's the vagus, right? The only thing I don't like, to be honest with you, let's see if I can find. Okay, I guess when I get there, we'll see. Okay, yes, I think it's the other question. Alright, so up B1 now, observe the structure elevated on pin B. What are the names in this section of the gut? What are their names in this section? That, again, that's another increased question. Vasa longa and vasa brevia. And brevia, yes. Yes, I'm not sure why they have just one thing here. But it can be longer and brevia.
Exactly, that's long and short. I don't make any sense. So I was wondering.
Yeah. Right. So look here, guys. Look here. So can I say something? So remember that the superior mesenteric and the inferior mesenteric anastomose are the artery of Drummond, right? And coming out of that artery now are these short and long vessels that go into the gut. Yes, so the long ones are the vasa longa, and the short ones vasa brevia. Okay. Yes, they're from the marginal artery of Drummond, guys. Alright, come, let's go. So identify structure A now. A. This is A. Okay, you can look on this. Alright. Alright? So again, open your atlas and look on the blood supply. I think the Netter has a beautiful thing. I don't see it in most of the other atlases, but the Netter have a good picture of the blood supply. So the middle colic. And you know that the right side of the superior mesenteric is where these vessels come from, but the left side supplies the small bowel. Right? So those vessels, the jejunal and ileal branches come from the left side, right? Yeah. Anyway. Who's that? The whole thing. Yeah, all the way around. Yeah. And surgically, it's very important too, you know, because of the anastomosis. In other words, you can have an embolus in, say, the inferior mesenteric, and the gut still gets supplied, because if the right mesenteric is, the superior mesenteric is okay, then the blood will just flow all the way around. Right?
Sir, sir, you said a spot where the...
Me?
Yeah,
Okay.
because this semester, you said something where you had the large bowel,
Yeah.
and it looked like it didn't look like you could see transverse colon from ascending and descending.
Mm.
So how would you know that that's middle, like transverse colon?
Yeah, well, again, you have to just try to fixate your mind on something that can help, like the cecum. So, you know, whichever looks bigger, then you're going to use that. So if you, that's in every spotter, before the man says start, you just, before you start, put pen to paper, just take a good look around and see if you can use anything to orientate yourself. And once you say cecum, that means that's the right side, right? And then when you say cecum, look if you can find appendix, but you have to look. You have to look. You know? Look also to see if you can find tinea coli on the gut. You have to look. You can't just panic or whatever, you have to look. Right? We all go through the same thing. We all go through the same thing. I get nervous when I used to do those exams, but you have to look.
Well, how would you know where like transverse stops and descending?
No, just look. If you see cecum, then the next stage after that, no matter if it's on the right or the left, if you see this big part, the next thing coming out of it is the ascending colon. Don't matter how they put it.
But sir,
You know?
what if that was straight up?
Suppose that was the rectum.
That would be terrible.
No, that would be terrible. They wouldn't do that.
They
then.
might bend it with the
Yeah,
transfer.
they wouldn't do that. They wouldn't do that. But you just have to find a way and look. You have to look, right? And remember now that the tinea coli are only in the colon, so you have to look. And you know the bowel that's joining the cecum will be smaller than the bowel that's leaving the cecum. Not true. So that one. So if you look and you see, you see the big part, that cecum, but you're not sure what one part is as opposed to the next part. The smaller of the two parts will be the ileum. So you just have to that's the best I can tell you. And I know that they sometimes bend up the thing deliberately to sort of confuffle you up. But you have to look. You have to look. The ileum obviously will not have tinea coli. Anyway, come, let's move on. So, let's move on, guys.
So wait, one more question.
Yeah?
You don't understand middle colic because why? What is that? Explain that.
Well, again, remember now, if you go back, so you see what they have done with that picture at the top. So, I guess whoever took this picture deliberately took that one, so for you to look and compare the two, right? So is there anything on the top picture that can help, guys?
It's showing you
Well, it's showing you
It's
what?
showing you the other two.
Yeah, it's showing you the other two vessels at the bottom.
The ileal colic and then the right
Yeah.
colic.
So remember, which is the what should I say now? Which is the first one to come off? To come off the superior mesenteric. So which is the highest? Which is the highest of the three vessels? So we have right colic, we have middle colic, and ileal colic, right? So which one we have first? The middle.
It was middle then right.
Right, and
then
ileal
ileal
colic.
colic.
Yeah. So all of these things you should have an idea of. You can just go in there and try to see if you can learn the thing. Some people ask me, how do you answer these things when you only have 2 minutes?
You have to know it before you come to the
Yeah,
exam.
you have to know it before you come to the exam.
Do we have time to do a endocrine spotter before?
have some endocrine here now.
Okay, but like a real.
Yeah, can do that. Yeah, we can do one tomorrow if you want.
Tomorrow's Monday.
Sir, are you serious?
No, I'm joking.
Can't joke like that,
Do you
sir.
see him
No.
in the week?
You can't joke if you're not ready.
No, but I have something serious, interesting to tell you guys. I have somebody who I'm going to ask. I'm asking, not Thursday, I'm not sure if we can go Thursday, but maybe Wednesday.
Oh, the same guy you're talking
Yeah,
about?
we can go through the pathology, pharmacology, and the physiology in one session. And he can go through all the past paper questions. Right?
In 2 hours.
I'm not sure if he can do it in 2 hours or 3 hours.
But you asked him to do it in 2 hours.
I asked him to do it. Okay,
You
come.
are dead. I
Come,
feel
come,
like you would
come.
need as long as.
Oh Lord, so guys, A2. So the middle colic, here it is now, A2, it may cause compression of a part of the gut. Name this part. So if you never know before, you now know that the middle colic can compress the third part of the duodenum. Third part.
Oh, yeah.
Okay? Now B1. The first group of nodes a cancer developing at pin B could spread to R. So right there. But should I put it on the big picture? Right? So the epiploic nodes, guys. Epiploic nodes. Huh? Epicolic, sorry. And then of course, as you know, eventually all the nodes will end up going to the pre-aortic node, right? Alright. Alright. Send this order. Alright guys, moving on now, quickly. The structure elevated by pin A. Pin A. The appendices epiploicae. Just for you to know, if you didn't know, what is the functional significance of those? And them store water and fat, right? Now look on pin, where the pin B's are. B1. Yeah, so they tell you pin B or L are related to diverticulae. This is one I say I don't like though. And you will help me. We'll work out why I don't like it. Why are they so popular in this part of the gut? Why do you find diverticular in this part of the gut? As far as I know, the only part of the gut that diverticular are popular is in the colon, right? We don't find them in the rectum, or we don't find them in the rectum for a reason. But I don't like the answer they give here. I mean, the second part, the high pressure, yes, but I don't like the narrow lumen and so on. And
You said to me to know that when we were learning it, you said the sigmoid colon, and you said because it's small.
no man, remember the main thing, you know, is the deficiency in the wall due to the tinea coli. So those parts of the sigmoid colon and the other parts of the colon that don't have no tinea coli, those parts of the wall are weak, right? And then that's what predispose the colon to diverticular disease. But remember also that the parts of the GI2 where arteries enter are weak too. And so those areas will also predispose to diverticular disease. Okay? And we also said too that those people who do not have a high fiber diet, when you don't have a high fiber diet, the bulk will not be there to generate the peristalsis. Okay? So what the bowel will try to do is to develop high pressures intraluminally. Right? And then the high pressures now will predispose to diverticular disease as well. Okay? But I don't think you can enter discussion about diverticular and don't mention tinea coli. I don't think you can do that. Not sure. That don't make no sense. It's just any part of the colon.
No, which part of the picture?
Huh?
What are the pins?
What?
Which part of the colon?
No, the pin is in the diverticular.
Which part
Where
Oh.
are we?
Well, I don't think you can tell. I don't think you can tell.
That's why we're asking.
Yeah, but remember now, once they're discussing diverticular, it must be colon. And it don't matter which part of the colon, because all parts of the colon have tinea coli.
Basically, because I'm mentioning narrow lumen on there. That's it.
Yeah. No, that's why.
That's why you didn't like the answer.
Yeah, I don't like that answer.
So you said your answer would have been this.
Or it's rectum where it is.
Yeah. So again, guys, nobody. You don't have people presenting in the hospital with diverticular disease of the small bowel. Nobody gets that. You don't have anybody presenting to the hospital with diverticular disease of the rectum. The only place you have diverticular disease is in the colon, and that's because of the tinea coli. You get me? Good. So I'm saying once they're discussing diverticular disease, the part of the bowel they're talking about is the colon. But I just don't understand why they can be talking about narrow lumen. Because you can't have a wider lumen. The part of the GI that have the widest lumen apart from the ampulla of the rectum is the colon.
Yeah, so I was asking you what would be your answer for the reason and why there's that part.
No, there's a possibility that, you know, I've seen wrong answers in the anatomy bank before. I've told you before, right? Yeah, it's a common occurrence. But the point is this: you cannot enter a discussion about diverticular disease and don't talk about tinea coli. In fact, that's the most important thing, right? If you look on a PowerPoint of diverticular disease, the tinea coli is the whole argument is centered around. And then they may say, you know, where the arteries enter is a weak point as well. But the tinea coli is the important thing. All right. Okay. And then of course, Go ahead. You want me? Oh.